In this research project, I wanted to take this opportunity to discuss sleepwalking, a fascinating phenomenon that occurs in up to 15% of the U.S. general population at least once in their lifetime. I am sure that every one of us is familiar with the experience of sleepwalking, either from stories we tell about ourselves as kids or through the experience of others that we have heard about. A friend of mine used to jump out of his bunk bed, run back and forth in the kitchen, and take everything out of the cabinets while he was sleepwalking up until the age of 12. Conversations about sleepwalking or about the funny things that we're doing in our sleep is quite common, but the underlying neuroscience and psychology of these things we do in our sleep is often overlooked as normal. In fact, sometimes these phenomena, depending on who is experiencing them and how severe or frequent it is, can be indicators of something much more serious and actually be unpleasant to someone who is experiencing this all the time in their life. So I wanted to take this chance to create an understanding of what mental disorders these behaviors can become hallmark in, and also to understand what is truly going on in your brain while you are sleeping. So according to the DSM, sleep-wake disorders are categorized into 7 different umbrella disorder types based on their unique causes and characteristics. First, there is insomnia, hypersomnolence, and narcolepsy, where insomnia is the disorder where a person experiences an inability to maintain their sleep or sleep for an adequate amount of time. Then there's hyposomnolence, which is a disorder where there is an excessive amount of sleepiness in addition to sleeping at the normal amount, where a person constantly feels tired and the need to sleep. And then there's narcolepsy, which I'm sure we know about, that disorder that is characterized by spontaneous falling asleep throughout the day, and it's uncontrollable. All 3 of these are the most commonly diagnosed in the United States, that are associated with problems of sleep and arousal systems in our brain that basically decide when we should be sleeping and how sleepy we are. There are other breathing-related sleep disorders that are involved with, obviously, respiration issues, but oftentimes it involves blockages of respiration due to different medical conditions, or those that involve the irregularity of breathing and oxygen or carbon dioxide maintenance. While you would think that someone who experiences disturbances to their respiration while they're awake would also have it in their sleep, really breathing is regulated differently during sleep than it is during arousal. There are also circadian rhythm sleep-wake disorders, which involve the irregularity and dysfunction of the circadian rhythm systems, which we've already briefly learned about. The regulation of our behaviors can be cyclical and controlled by this system, and it accounts for environmental stimuli to initiate certain behaviors throughout the day. In this case, sleep is very much regulated by light and darkness in our environment. Therefore, someone who has problems with their circadian rhythms could have detrimental impacts to their ability to sleep at the right times for long periods of time. The one we're going to be focusing on in this presentation is parasomnias, which are certain unusual sleep behaviors or experiences that are disruptive to sleep patterns that occur at various stages in sleep. This could include something called nightmare disorder, which we won't be talking about, but in nightmare disorder, a person experiences recurrent, vivid, and disruptive nightmares that are detrimental to their health. Sleep-wake disorders can also be initiated by the use of certain drugs, obviously because drugs modulate the amount of certain neurotransmitters in your brain and how your body reacts. Therefore, behavior will be modified as well, and any other sleep-wake disorders that couldn't fit into any of these categories would be considered other unspecified, as long as it's dysfunctional enough to disrupt somebody's personal and occupational life. It can be considered a sleep-wake disorder. In general, sleep-wake disorders are found to be comorbid with other disorders such as depression or anxiety. This is true for parasomnias as well. Any of the structured disorders, when properly diagnosed, can be suggestive of certain risk factors for the development of other conditions. Because of the biological nature of these disorders, oftentimes sleep-wake disorders are risk factors for medical conditions such as neurodegenerative diseases that are influencing the structures in the brain that handle the induction, propagation, and waking from sleep. It could also be an indicator in the case of sleep apnea or respiratory sleep disorders, of respiratory or cardiac problems. This is why it's important to pay attention in your own sleep behavior and the behavior of others in your life, as some of these disorders could be a sign of something much more serious. Sleep occurs in stages, and because all of these disorders are related in some way to the sleeping patterns we are experiencing, I think it's important to go over them. So the stages of sleep that control our sleeping patterns are rapid eye movement sleep, which is the time in which memories are likely being consolidated and the most brain activity that's reminiscent of your brain while it is awake is occurring. And then there's light and deep sleep, both of which are categorized as non-rapid eye movement sleep. A person who is woken up during REM sleep tends to wake up alert and aware due to the nature of the brain's activity during that time, but people who are woken up during non-REM sleep are often confused and slow to alertness, and this will be important in our discussion about sleepwalking. So here's just a diagram demonstrating where some of these sleep-wake disorders are categorized based on the sleep stages that we go through. The ones that we're going to be focusing on are disorders of arousal, which are somewhere between non-REM sleep and wakefulness. So what is non-rapid eye movement parasomnia? Non-rapid eye movement parasomnias, which are categorized differently from rapid eye movement parasomnias, occur when there is abnormal behavior, experiential, or physiological events that occur during the sleep stage of light or deep sleep. In previous DSM versions, specifically the DSM-2, this used to be referred to as confusional arousal. There are two observable types of events that fall under this category of parasomnias, and that includes sleepwalking and sleep terrors. So sleepwalking is, as you know, observable and complex motor behaviors that involve rising from bed or certain facial expressions. Usually these people are very unresponsive to communication from others and are extremely difficult to awaken. Sleepwalking can be further categorized into eating behaviors or sexual behaviors that occur during sleep, which is considered to be rare but also something to note. Most occurrences of these behaviors can last as long as 1 hour, and people who experience sleepwalking will usually have their eyes wide open but are unresponsive, still in a state of partial arousal. So this can actually become dangerous for some people. There are stories about people who would sleepwalk and drive or sleepwalk and cook, and this can be dangerous if no one is there to recognize that this is going on. Sleepwalking is also known as somnambulism, which was used in the DSM-4 to describe this phenomenon. The other event that could render a parasomnia diagnosis would be sleep terrors, which are abrupt terror arousals from sleep with a clear autonomic arousal response despite not rising from the bed, accompanied by unresponsiveness to others during the episode. This can involve screaming because the person is experiencing an inability to move. In both events, a person is unresponsive to waking as they are in the deeper stages of sleep or slow wave sleep and often cannot remember at all that they had such events happen to them. So there's amnesia involved. And there is little to no dreaming associated with the event that would help them remember what they were doing in the situation. If you recall the diagram shown in the previous slide, non-REM parasomnias differ from REM sleep disorders and nightmare disorder in that there is no alertness or recollection of the behavior upon waking, as it occurs during a completely different stage of sleep. As you might have already guessed, sleepwalking, although something that can occur at any age, is most commonly diagnosed and observed in childhood. This is due to the mere fact that a child's brain is not fully developed yet and is constantly undergoing growth and changes during this critical time that might disrupt sleep. 10 to 30% of children have been reported to have at least one episode of sleepwalking in their lifetime, with at least 2 to 3% of them sleepwalking often. There appears to be a familial vulnerability to experiencing sleepwalking as a child, where approximately 80% of the individuals who experience sleepwalking have a family history of this behavior. This risk is even further increased if both parents have experienced sleepwalking. However, there has been no genetic cause or specific genes linked to this condition, other than the familial frequency to link sleepwalking or parasomnia behavior to that patient's experiences. Sleepwalking is a phenomenon that occurs in the highest frequency in childhood and therefore decreases in frequency with age. There have been many studies that have demonstrated that a child who has sleepwalking episodes, the number of episodes that are occurring over their lifetime decrease as they age. It is theorized that this has much to do, again, with the development of the brain over time, as the brain is not fully matured even through adolescence and young adulthood. So this graph is just demonstrating the percentage of new cases that come up from either sleep terrors or sleepwalking, where the diagnosis of sleep terrors can occur much earlier or higher in frequency the younger the child is, and sleepwalking occurs from anywhere between 3.5 to 13 years old. After this, the percent of new cases is almost minimal, despite unique situations where, for example, in adults, Instead, sleepwalking develops in adulthood, and this is often a sign of concurrent medical or drug-induced sequences of changes leading to the behavior, because this is uncommon. In adults, the presence of sleepwalking behaviors have actually been shown to be comorbid with depression and anxiety, but specifically OCD diagnosis. It has also been shown that there is a relationship between sleep deprivation and the increased occurrence of sleepwalking in adults. The neurobiological etiology of sleepwalking is relatively unknown. Of course, it is hard to understand how sleep is manifested in the brain other than by looking at the activity of the brain during sleep, where complex motor movement is occurring during sleepwalking. Sleep studies have been important in understanding at which point during the sleep cycle these behaviors are happening, but it's still unknown what triggers the behavior itself to happen. It has always been a myth that the experience of sleepwalking is really just enacted dreams brought to life by a person's behavior. In fact, it's quite different. It is instead true that sleepwalking is somewhere on the spectrum between deep sleep and full arousal, where a person is enacting complex motor behaviors as if they are fully awake, and the brain is not entirely conscious of this. I think that this really drives home the message that sleep is not a global experience, meaning that there are parts of the brain that lie dormant while we rest and other parts that are fully aroused. The miscommunication in the brain that occurs during sleepwalking is that of the motor system not recognizing that the rest of the brain is not aroused with it. Most sleep scientists hypothesize that the occurrence of sleepwalking is due to the dysfunction of the circuits that control sleep arousal systems that trigger the activation and inhibition of certain brain areas during sleep. It is also theorized, and I believe most importantly, that due to the activation of the motor systems during sleepwalking, such as rising from bed, turning doorknobs, yelling or talking, or cooking pancakes in the kitchen, it's a lack of GABAergic inhibition that is contributing to the unwarranted activation of the motor system. GABA plays a very important role in the inhibition of neuronal activity. In this case, it is the inadequate inactivation of the motor system during sleep. This is evident in that benzodiazepines, a drug that enhances the activity of GABA, has been shown to decrease the occurrence of sleepwalking in chronic adult sleepwalkers. So it's honestly really easy to diagnose sleepwalking, and the fact that it's self-diagnosable, either by yourself waking up somewhere in a very odd place, or in the middle of doing something upon waking, or by a family member who's observing it. If someone becomes aware of the behavior and it's causing severe disruption or injury to their life, the next course of action would be to undergo a sleep study or polysomnography in order to properly diagnose the behavior as occurring during slow-wave sleep. Here on the right is actually the polysomnography results from an individual experiencing a brief episode of sleepwalking and talking, where their brainwave activity has changed as a result of the behavior, shown here. But they still remain asleep despite the arousal. It is also important that clinicians are able to rule out the use of drugs or the presence of another medical condition as a possible cause for the sleepwalking. This is important for planning the treatment of the disease. So treatment oftentimes for sleepwalking requires a multidimensional approach and could be variable depending on their circumstances. If the patient has been using drugs or is experiencing another condition that is contributing to sleepwalking, these conditions would be treated first and foremost in order to see if the treatment of those conditions would relieve the sleepwalking. In the event that a person is using drugs that are changing behavior, discontinuing the use of those drugs could potentially relieve it. If this does not change anything, there are some pharmacological solutions that have been demonstrated to decrease sleepwalking. The apparent most effective drugs would be sedative hypnotic drugs, which promote steady and uninterrupted sleep cycles, and other sleep-wake disorders, or benzodiazepines, which we've already discussed as enhancing the activity of GABA. The mechanisms by which these drugs accomplish this alleviation of sleepwalking is unknown, but it's still effective. The other drug that has been shown to be useful in only a few cases is antidepressant medications that inhibit serotonin levels. In children, it is so important to make sure that parents and guardians understand the importance of safe sleeping environments, because children are the most likely to experience sleepwalking. Ensuring that they cannot injure themselves in their sleep as is occurring can be accomplished by removing things from their room or placing things out of reach in your home that could potentially cause harm. So I have personally learned many things from this project, and I hope you take away some of these lessons with you as well. Never abruptly wake a sleepwalker. It's much like turning off a computer while it is loading a program. It can be dangerous to the person experiencing sleepwalking. Sleep and wakefulness are not mutually exclusive, as evident by some of these behaviors. Sleep is not a global whole brain phenomenon that is experienced by the whole brain all at once. Instead, it's always somewhere in between, and there are still many unknowns about the regulation and dysfunction of parasomnia sleep behaviors, especially sleepwalking. I hope you enjoyed. Thank you for joining me.